Hello and welcome to Medical Ethical Decision Making During Pandemics, brought to you by Canadian Associates of Ben-Gurion University, also known as CABGU, and the Canadian branch of the International Federation of the Israel Medical Association. My name is Galit Solomon. I am the Director of Marketing and Communications at CABGU, and it is my pleasure to host and moderate tonight's timely and relevant conversation. Thank you all for making the time to join us this evening. We also wish to thank the sponsor for tonight's event, the Dr. Edward Feldman Memorial Fund. We are fortunate to have a panel of three renowned medical experts from Israel and Canada. Tonight, you will hear from Dr. Sandy Buchman, Dr. Yoam Singer, and Dr. Eliot Malamet. The idea for this evening's virtual gathering stems from the great need now more than ever to stay connected, informed, and healthy. COVID-19 has forced us all to consider our mortality, raising questions about the ethics behind certain medical decisions. Both CABGU and the Canadian branch of the International Federation of the IMA have a stake in the medical field, and it feels natural for us to collaborate on this very relevant and important topic. And so on that note, we begin with greetings from the CEO of the Canadian Associates of Ben-Gurion University, Mark Mendelson. Over to you, Mark.
Friends, good evening. Erev Tov, bonsoir. I am thrilled to bring greetings to today's joint program with the Canadian branch of the International Federation of the Israel Medical Association of Canada, led by Dr. Rose Geist, which will feature a most illustrious group of medical professionals in Canada and in Israel. As the son of a family practitioner who graduated McGill Medicine in 1940, I am very sensitive to and especially supportive of everything in the field of medicine. And I'm thrilled to say that we have almost 300 participants registered for today's webinar. It is fabulous and fantastic. I'm also honored to be able to represent Israel's youngest and most dynamic university, or as we like to call it, Israel's nation-building university. I'm so proud of our two medical schools, one which is taught in Hebrew, and the one taught in English is the only one in Israel with a global medicine approach, which sends its fourth-year students to work for a semester in a developing country outside of Israel. And thanks to the wonderful generosity of Gary and Tamara Fine and family, we are able to offer some financial assistance to Canadian students who are accepted to study at our Medical School for International Health in Beersheba, the MSIH. I urge all Canadian students to think about us as a potential place to study medicine and check us out on our website. Why, though, are we so special? The following small example really exemplifies our uniqueness within the university fabric of Israel. If one would remove any of the other outstanding universities in Israel from their cities in which they are found, Tel Aviv University from Tel Aviv, a Hebrew University from Jerusalem, the Technion from Haifa, nothing would happen to the city in which they are found. The cities would continue to thrive and grow because they have the Knesset, they have a huge population, they have an industry base, etc. However, remove Ben-Gurion University from Beersheba, and I hate to say it, but not only the city, but probably the entire Negev region of Israel with its 1 million Jewish and Bedouin population would not be able to survive and thrive. We are truly the engine that feeds and drives this area. We are indeed the jewel in the crown of Israeli universities, and I urge and invite you to visit us on our website, www.bengurion.ca, but even more so, come visit us in Beersheba in person. Special thanks to our Toronto Executive Director, Shimi Wenner, for his outstanding work in organizing this event, to Zach Ostrov, our Executive Director from Winnipeg, for his technical acumen, to our wonderful Director of Communications and Marketing, Galit Solomon, and to our partner in this excellent program, Dr. Rose Geist. I'm sure this will be an outstanding evening.
Thank you, Mark. And now here is Dr. Rose Geist, the president of the Canadian branch of the International Federation of the Israel Medical Association. Dr. Geist, the screen is yours.
Good evening, everyone. I'm a psychiatrist in the Department of Psychiatry at the University of Toronto. I've had the wonderful opportunity to be the president of the Canadian branch of the International Federation of the IMA for several years, and this has been a particularly exciting year for our growth. First and foremost, I would like to thank our new executive, Dr. Daphne Grossman, Ms. Benita Joss, and Dr. Roger Goldstein, who have worked with me with our BGU colleagues to help bring this extremely important webinar to you this evening. The CIMA, as we are called, was formed in 1945. It is a medical association which is Canadian but based mainly in Toronto. It has clearly evolved since those post-war days to meet the present needs of our Canadian-Israeli medical community. We are focused now on collaborative initiatives, and most recently, we have partnered with the wonderful work of BGU. A central goal of the CIMA is to create educational events and to support Canadian medical students who study in Israel and Israeli residents and fellows here in Canada. We have provided several fellowships to students who wish to study medicine in Israel, a significant number of whom have gone to the International Medical School at BGU. Our highly committed physician membership continues to grow, and we invite you all to join us as members and to help make these wonderful events happen, and to support our medical students and our educational events. We are very much looking forward to joining you all in a very stimulating evening.
Thank you, Dr. Geist, for your remarks. Before I introduce our first speaker for tonight, I would like to remind our audience that we are live tweeting throughout the evening. To join the conversation, head to our Twitter account at Ben-Gurion Canada, and please remember to use the hashtag Ethics of COVID. And a note, we are also on Facebook Live. In terms of the format for tonight's discussion, we will introduce each of the three presenters just before they share a 10-minute presentation. Once all three speakers wrap up their presentations, we will move on to a discussion, which I will moderate. We will then open up the floor to questions from attendees. Please use the Q&A box at the very bottom of your Zoom screen to submit your questions, and we will do our absolute best to get around to as many questions as possible. Well, it's time now to hear from our presenters. First up is Dr. Sandy Buchman, a palliative care physician and the Freeman Family Chair and Medical Director of Palliative Care at the Freeman Center for the Advancement of Palliative Care at North York General Hospital. He is also the immediate past president of the Canadian Medical Association and an associate professor with the Department of Family and Community Medicine Division of Palliative Care at the University of Toronto. Dr. Buchman, the screen is yours.
Thank you so much, Galit. Good evening, everyone. Erev Tov. And again, thank you for this very generous invitation to address you today. I'm deeply appreciative and to be on a panel with my esteemed colleagues. And speaking to you from Toronto, I wish to respectfully acknowledge that I am on the traditional territory of the Mississauga, Anishinaabeg, and the Huron-Wendat. This territory is covered by the Williams and Upper Canada Treaties. I offer my gratitude to our First Nations for their care of and teachings about our earth and our relations. May I honor those teachings. Next slide, please. So this is really just my disclosure. I have no commercial interests or conflicts. I do receive a stipend as CMA past present. And you will see some photographs as part of this presentation that were taken by a good friend of mine, a fellow named Kingsley Watts, as he traveled across the country in a self-constructed and socially isolating RV. Next slide, please. So these are what I see as the ethical challenges of the COVID-19 pandemic. The pandemic has revealed very serious gaps and weaknesses in our healthcare system in Canada, but has confronted us with these challenges, and these necessitate really complex decision-making. So some of these challenges include the vastly disproportionate impact of the pandemic, including death in our long-term care residents, amongst our racialized citizens, and those experiencing homelessness. It's also led to frontline healthcare workers taking significant risks, as they may not have been adequately protected against COVID-19 due to lack of personal protective equipment. This is particularly concerning in the first wave. Another issue is the critical care triage that we're preparing for as hospitals become overwhelmed. And as well, as a palliative care physician, I had a great concern that there was lack of attention to palliative care in many jurisdictions. I'm also going to add, I think in this presentation, this is an older slide, of something about vaccine prioritization. Next slide, please. So here are some of the headlines that we have been reading in Canada, and these have occurred again now during the second wave. Canada was not prepared for the pandemic, especially in its inability to care for seniors in long-term care. About 8 in 10 COVID-19 related deaths in Canada have been in long-term care, double the OECD average in the first wave. By July of 2020, the National Institute of Aging reported that more than 18,000 cases and almost 6,900 deaths among residents of long-term care and retirement homes in Canada. And there were even about 10,000 staff cases and 16 deaths. Next slide, please. The Canadian Institute for Health Information reported in the first wave that Canada fared just below the OECD average in the number of deaths per million. However, as mentioned, 81% of all COVID deaths in Canada occurred in long-term care, the worst percentage of all OECD countries and more than twice the OECD average of 38%, as you can see in the bottom row. The Tracker Open Data Working Group, as of the 1st of October, found that approximately 21,000 of these residents have been infected with COVID-19, and over 7,400 of them died as a result, again, amounting to 80% of COVID-19 deaths in Canada at the time. Next slide, please. This is a busy slide, but it's an up-to-date data, and I'd just like you to look at the bottom line. I mean, that shows you everything from the total cases and total deaths up to February 5th, so just a few days ago. But as you can see, it's really the last number in the corner. 68% of all deaths now is the number that we're seeing in Canada in long-term care. And according to the National Institute of Aging, there are numerous reasons for this very sad and tragic occurrence. There was lack of PPE for frontline healthcare workers, insufficient infection prevention and control expertise, very uneven clinical leadership. Personal support workers have had to move from home to home just to cobble together some full-time employment. There's inadequate staffing ratios, leaving residents neglected as the surge hit. There's been chronic under-resourcing of our long-term care. Some of our older structures have more than 4 residents per room, and many other risks. You know, so these are just a few of the issues that we have in long-term care. So how did we let this happen? We knew about these issues for the last 20 or 30 years. There's been countless reports. I believe it's an incredible moral failing of our society as revealed by the pandemic. Next slide, please. And so we know the numbers. But with regard to palliative care, there is much we do not know. And so these are my questions that you see before you. They disturb me greatly. My suspicion is that most of the seniors who died in long-term care did not receive adequate palliative care. Dedicated nurses and personal support workers who cared for them were just too overwhelmed to offer much more than a hand and calm words through a barrier of PPE. Again, simply put, we weren't prepared. So I really think we could have even helped with having a palliative care approach integrated into long-term care. We know that's been lacking in many long-term care facilities across Canada. And I don't think we can ever right the wrongs of this shame until we do, in addition to all the changes that need to be made, integrated palliative care approach. Next slide, please. I published a paper in the Canadian Medical Association Journal in March on pandemic palliative care. I proposed at that time that equitable access to palliative care is a key consideration in a pandemic. And we don't do too well on that front in Canada either. And this is where I've been working in the last few years, in the city streets, in the homeless shelters, in the rooming houses, boarding houses. These patients with COVID are unable to self-isolate and are also at risk because of the multiple comorbidities they live with. An Ontario-based study recently published in the Canadian Medical Association Journal reported that homeless individuals are 20 times more likely to end up hospitalized with COVID-19 and 5 times more likely to die from the disease due to a combination of underlying comorbidities and social conditions. You know, those more marginalized are often not supported by family and loved ones. They may have mental health, addiction, behavioral issues. And though the lack of advocates for them in our healthcare system puts them at risk of being abandoned by that same healthcare system at a critical time, such as triage. Again, there may be systemic biases against those of indigenous and racialized backgrounds and people experiencing homelessness. In our paper, my co-authors and I made a plea that all patients must be cared for. Palliative care becomes a compassionate option to counter that inequity. Next slide, please. But no matter how compassionate we are limited by the societies and the healthcare system in which we work. One of those limitations is the injustice of systemic racism. And you can see just here in the slide on the left, if you look, these are recent data from Toronto that shows the disproportionate impact. For example, Blacks make up only 9% of the population of Toronto, but 16% of the COVID cases. The South Asian or Indo-Caribbean community makes up 13% of the population, but 27% of the COVID cases. While the white population on your far right shows that whites make up 48% of Toronto's population, but only 21% of the COVID cases. So again, evidence of the disproportionate impact. Approximately 83% of all COVID cases have occurred in the racialized population. And even looking at the palliative care question, there's delay. It takes longer to get a referral to palliative care because of their background. There's implicit bias here, and that's a risk at triage. And the essence of palliative care is really to honor our patients' values and identities, and we have to practice inclusive care of people from all backgrounds. We have to demonstrate cultural immunity, and we must adopt anti-racist stance. Next slide, please. One of the things, as I mentioned earlier, was the lack of PPE, placing frontline healthcare workers at risk of harm. This was a huge issue in Canada at the first wave, and you know, it still is. We still have some community-based physicians and other providers who only have a couple of days supply of PPE. You know, and I liken it to expecting a firefighter to enter a burning building without adequate protective equipment. We would never expect that. So how did we expect our frontline healthcare workers to put themselves in harm's way and their loved ones without adequate PPE? Why were they asked to do so? You know, frontline healthcare workers have a call to duty, but I also believe the government has an ethical reciprocal obligation to protect all frontline workers who place themselves at risk of harm. And our government was negligent in fulfilling that obligation. They were caught flat-footed in not preparing for this pandemic. There's not only was it for PPE, but there's also a great supply of critical care medications. These were key recommendations in the SARS Commission report. So after the SARS affected Toronto particularly, but many places in the world in 2003, a full report came out and said we had to stockpile these medications, we had to stockpile PPE, and it wasn't done. It was basically neglected. Next slide, please. We have the critical issue of the resource allocation of critical care. And here were just some of the guiding principles. Again, this is an option of last report. An emergency standard of care is appropriate to mitigate the worst effects of the surge. In Ontario, we have a critical care triage plan. Patients will be prioritized for those who have the greatest likelihood of survival 12 months from the onset of critical illness. And the primary overarching medical obligation must be to save the most lives possible. The overarching legal obligation must be non-discrimination and protection of human rights through processes that promote fair, equitable, and evidence-based clinical decision-making. We also need a very clear, transparent, and accountable system that's applied across all patients, all hospitals, and all regions. That's the optimal way to support fair and evidence-based decisions, protect human rights, to minimize the risk of discrimination and unconscious bias. Next slide, please. This is just briefly, when I did some research on looking at the palliative care response in humanitarian crisis, I found it was particularly absent. It was suboptimal. There was a case during the Ebola crisis where, in the absence of palliative care specialists, overworked healthcare providers really struggled to care for patients with the disease, but expressed frustration when they were required to turn treatment facilities into facilities that cared for the dying. It just wasn't valued. Next slide, please. So to me, providing palliative care in a pandemic is an ethical imperative. We can't abandon the dying, and no one should die alone. And that's what's happening with our restrictive visitor policies. We can address that through video technology, or we can address that by providing family caregivers with personal protective equipment to be there. And given the potential of scarce resource allocation, hospital palliative care teams are really well suited to help patients and those who care for them to discuss their advanced care plan, to discuss their goals of care. We're doing this in a program right at North York General right now. We want to provide the care wanted by patients and families. Next slide, please. We have to have the expertise to participate in resource allocation. Otherwise, it really is a travesty of justice. Next slide, please. I had a whole slide. We made an error in this draft of the presentation, but it is on some of the issues that we must do to prioritize who gets vaccinated. And very briefly, and I can talk about this later, we have to prioritize those who, of course, are at high risk with advanced age and high risk health conditions, who are likely to transmit it, the virus to those at high risk, like frontline healthcare workers and household contacts. We have to look at people who contribute to maintenance of essential services, those who can't work virtually, and those at high risk of infection because of their living and working conditions, and those who live in congregant places like shelters, for example. We have to base our sequencing on the risk analysis, on safety, on effectiveness, and on the vaccine characteristics, the supply, and epidemic conditions. And so really just to summarize, you see the disproportionate impact of the pandemic on the frail elderly and those experiencing homelessness, I believe really was a moral failure of our country. Placing frontline healthcare workers at risk of harm without adequate PPE was also a glaring failure. It is still a challenge. The resource allocation of critical care in the context of limited hospital capacity is perhaps the most challenging issue of our time. And the lack of palliative care availability or inclusion for patients dying of COVID-19 in many jurisdictions is also, too, I think, a moral failure. We just can't abandon the dying during this pandemic. Next slide. And really just to wish you thank you. Really appreciate the opportunity to address you tonight. Galit, I think you're on mute.
My apologies for that. I was just saying, nobody could hear me, but I was just saying thank you so much for that eye-opening presentation. And really, you know, when you're looking at the facts and these numbers, it's sobering and it's disturbing at the same time. You will be coming back, of course, for Q&A in a couple of presentations. So please hang tight. We're now going to take a deeper dive into some of the issues surrounding decision-making in the face of life-threatening illnesses. Speaking on the topic is Dr. Yoam Singer, a physician with the Department of Family Medicine, Palliative Care Unit with Ben-Gurion University, currently on a one-year sabbatical in Ottawa. Dr. Singer, the floor is yours.
Thanks. Thank you very much for giving me this opportunity. What I will do is go a little bit from the general to the individual. Next slide, please. So most of what I will say refers, and Dr. Buchman stated it so very clearly and obviously, relating to the frail, the elderly, the underprivileged, and people suffering from pre-existing conditions that puts them in a particularly vulnerable situation with regards to COVID infection, both of becoming infected and dealing with the infection once it's there. So I'm going to go down to the details of that. Next slide, please. Let's think a little bit of what the clinical setting of these individuals is. There are often people who live alone, either at home or in a care facility. Very often they may be in quarantine. And if not, we've had now almost a month and a half of total lockdown, which means total isolation, inability to communicate with anybody or anything at all. There are, as we mentioned before, there are difficulties in accessing medical care. And we mustn't forget that very often from onset of COVID-19 disease to deterioration may be very, very, very quick. And there'll be maybe no time to prepare adequately for what's going to happen. And this terrible feeling of unknown, this terrible feeling of constant threat. Next slide, please. And we talked a little bit before, and I want to emphasize it again, about the availability of medical care. Many doctors just don't do home visits. It's not available either because they've never done it or because they're so overworked in their practices that there's literally no time to do it. Many medical personnel are very hesitant and ill-equipped to doing home visits and caring for patients at home. And on top of all that, the patients very often don't really understand what the full meaning of hospitalization is actually. Next slide, please. Most people in this country, in Canada, and in Israel as well, do not have advance directives. So there's nothing we can base on our assumptions as medical caregivers. And so very often we have to try and understand what the patients really want, what their choices are in very, very challenging conditions. You can imagine what it's like to have these kind of conversations by WhatsApp phone or by Zoom or not having any sort of personal contact. And very often people don't understand really not only what the options are, but what the meaning of each and every option is. What does it mean not to decide not to go to the hospital? On the other hand, what does it mean? What are the consequences of being shipped to the hospital in all dimensions? And it's very important that we make some kind of provision for enabling people to make informed choices. It's not good enough to say, listen, you have to decide whether you want to go to the hospital or be treated at home. What does that mean? Most people have not the faintest idea. It's also very, very important to involve not only the patient, but their family and their caregivers. And how do you do that in a situation where there's quarantine, where there's isolation, where it's not allowed even to enter the care facility where the patient is? So all of these things have to be taken into account and thought about. Next slide, please. So the question is whether when you give somebody the option of home care, is it feasible at all? Is there a medical personnel who will do the home visit, who can care for the patient at home, who can be available as to be in face of sometimes very, very quick deterioration? It's not a chronic condition which, if you can't come today, will come tomorrow. It doesn't work in COVID-19. If you come tomorrow, there may be nobody to come to. On the other hand, the meaning of hospitalization is very often isolation from family, from friends, from loved ones, and the possibility of undergoing invasive treatments which you may not want at all. So that's what's coming, what's in front of you. Is home care possible? On the other hand, do you really want to be in a hospital? And on top of all that, what is the prognosis of ventilating? For example, somebody who's 89 years old, has multiple morbidities. What are the chances once he gets respirated of being able to be weaned off the respirator and continue his life as it was before. All of these things must be taken into account, must be presented to the person who's making the decision. Next slide, please. So I think that in order to ensure the basic right of autonomy and enabling somebody to decide what he really wants in face of this pandemic, I would encourage all healthcare workers to initiate a discussion on choices. Not only what the choices are, but what the meaning of each and every choice is, especially in people who are more vulnerable, and it may be very challenging for people who have more difficulties in understanding what's going on. Next slide. And finally, I'd like to point out, and this is something that's been researched 101 times in palliative care milieu. When asked, most people facing life-threatening conditions would prefer to stay at home in familiar surroundings, surrounded by their loved ones. And I think that's something that must be taken into account. And I would like to take this opportunity to urge policymakers to enable this to happen, to enable medical teams to come home, to come to the home, to be adequately protected, to have the time to make these conversations and be available 24 hours a day, 7 days a week, in order to care for these people in a situation where changes are very, very quick. These services, of course, must be accessible to all, regardless of where they live, regardless of their financial situation, regardless of their belief or anything else. Thank you very much.
Dr. Singer, thank you so much for that thought-provoking presentation, and we look forward to speaking with you during the Q&A. And just a reminder to our audience members that if you do have questions, you may enter them at any time leading up to the end of the next presentation and beyond. And it is now time to present our final speaker for the evening. To round out the presentation portion, I would like to call on Dr. Eliot Malamet, who joins us all the way from Israel this evening, where it is past 3 o'clock in the morning, I believe. We thank you for staying up and for joining us. Dr. Malamet is a lecturer in Jewish ethics at the Schechter Institute in Jerusalem, professor of Jewish studies at the University of Waterloo, and a lecturer in Israeli literature at Hebrew University. Dr. Malamet, the screen is yours.
Thank you, Galit. Hi, everyone. If you've ever been in an emergency room in the middle of the night and you're waiting to be treated, so you've experienced the inevitable frustration that comes with seeing other patients being taken ahead of you, even if you arrived at the hospital first. And at that moment, you've been subject to a method of decision-making known as triage. And tonight I want to talk to you a little bit about the ethics of triage. Unlike my esteemed colleagues, I'm not a physician, but I teach ethics and philosophy. So let's talk about triage, which ordinarily is when you go to a hospital and there's an assignment of degrees of urgency to the wounds or illnesses, and they decide the order of treatment. In cases of war or natural disaster, they decide which casualties require immediate life-saving attention. So during the past year, as you all know, medical ethicists and hospital administrators around the world have been involved in agonizing life and death decisions during the pandemic, many of which have to do with triage, for instance, on how certain vital resources like ventilators or now vaccines should be allocated. So I want to throw out a case to you and think about it. Imagine, for instance, that you have 3 patients. One is an adolescent boy with a pre-existing asthmatic condition that's serious. One is a 35-year-old mother with 3 children. And then a 75 to 80-year-old grandfather. And all have contracted COVID and all are struggling to breathe. But in this hypothetical scenario, there's only one ventilator available at the hospital. Who gets it? And on what basis do you decide who gets it? Is it the one who arrived first come, first serve? Is it the one who is sickest? is it the one who has the best chance of getting better if they're given the ventilator? Or from another perspective, is it the one who has the most quality time left in their life should they recover? Or maybe the mother who has the most dependence. So you're the doctor in charge of the decision. What would you do? So I'd like to very briefly outline for you some of the possible ethical approaches to these dilemmas. There's a very fine bioethicist at Stanford named David Magnus, who's the director of their Center for Biomedical Ethics. And he's basically outlined three positions that relate to triage. One is called egalitarianism, one is utilitarianism, and one is prioritarianism. Big, long words, but we'll break them down. Each theory has pros and cons, or more accurately, parts of each theory seem more ethical than others. So let's go through them, and I'm just going to try and share my screen here and show you one of these theories. All right, so here are the three ethical theories. Egalitarianism, which seeks to treat patients equally. It's just as it sounds, right? Let's try and have everything equal, no deference paid to their age or their level of sickness, first come, first serve. Maybe on a societal level, if you're talking about vaccines, it would be like a lottery system to allocate resources. And it has the virtue of blind luck because nobody is favored over anyone else. It's just simply a matter of who happens to be admitted into the hospital when the ventilator comes free. Second, utilitarianism, which actually goes back to the 19th century, to the British philosophers Jeremy Bentham and John Stuart Mill, who argue that the goal of ethics is to achieve the best possible outcome for the greatest number of people. So utilitarianism claims to be a theory that wants to promote maximum possible benefit. But how do you measure that in the age of COVID? So as you see here, a strict utilitarian might ask, who after receiving treatment would have the best chance at a long and healthy life? Should we really put your sick and frail 90-year-old mother on a ventilator and take it away from the reasonably healthy 30-year-old if there's only one ventilator available? Who's likely to maximize quality life years? Even if the candidates are of the same age, let's say, then based on an assessment of how sick they are and what their chances of recovery are, who would be most likely to get well and live a long life, that would be a utilitarian consideration. And I know, as I'm saying this, that for many people, this sounds quite cold and unfeeling. But unfortunately, in times of crisis, it may come down to mutually exclusive decisions. It may come down to having two people vying for the only remaining machine. Our third theory is called prioritarianism. Again, as it sounds, it prioritizes those who are in the worst medical condition. It advises treating the sickest people first, regardless of how old they are and whatever their chances are of recovery. So emergency rooms will often operate on this principle. For example, choosing to treat the gunshot wound victim before the person with the broken finger. So here you have three theories, and they're all addressing basically radically different points of view in terms of how to treat people. So let's delve a little further into this. Each of these theories can speak to some of our moral intuitions, but you could see they each raise serious problems. Let's take the first one, egalitarianism, treating patients equally, so to speak, is to treat them without any distinctions, which means that you're not taking into account their age or the severity of their condition. Is that fairness exactly? Is equality the same thing as fairness? So it could lead to an unwise use of resources. Utilitarianism, I think, is the theory that makes us a bit squeamish here because it does the opposite of egalitarianism. It actually makes rankings and evaluations of quality of life, right? So the utilitarian approach is looking at you and thinking, are you worth saving? So in that sense, if you make your decision that way, you could end up neglecting the sickest people and opting for those you think you can save and actually ignore the fact that you may be guaranteeing death for certain patients. The last theory, on the other hand, prioritarianism, in which you devote a lot of attention to a very sick patient when you could have generally saved a somewhat less sick patient, leads to the question of whether we've just wasted a very valuable resource, and how do we decide, right? So these are some of the dilemmas that have been going on globally in every hospital room, in every hospital, in every country in the world. I just want to mention briefly how Jewish ethics might begin to approach these problems. So one stream of thought, which was championed by the late Orthodox Rabbi Moshe Feinstein in the 1980s, more or less reflects egalitarian theory. He argued that if a patient is already being treated, so the patient came in and they put the patient on the ventilator, even if the physicians didn't judge the situation exactly accurately, in other words, they misread the patient's survivability and they mistakenly allocated resources to the patient's care, Rabbi Feinstein says that another person with higher chances of survival doesn't take precedence. You can't take the person off the resource once you put them on. And that the patient doesn't have a moral obligation to surrender the resource to somebody else. So in fact, what happens is that the resource becomes the patient's for as long as they maintain life. Now, it's obvious that this doesn't necessarily mirror hospital policy. Right? The hospital might make an assessment to reevaluate and even to reallocate resources in the hope of maximizing the number of people they can save. But his position was placing a kind of primary value on stopping any kind of active killing. But this is crucial. And I just want to wrap up by saying that his view is only talking about a post facto case. The person was already put on the machine. But what about prior? What about if you are in the position now of making the decision before any final determinations have been made about who to give the resource to? So there's an amazing rabbi out in Los Angeles named Jason Weiner. He's the director of the spiritual care department at Cedars Sinai Hospital in LA. And he argues that in general, one of the fundamental principles of triage in Jewish law is that you actually give priority to saving as many people as possible. In other words, he's inclining to the utilitarian view. So in fact, rabbis might encourage before the fact, I mean, this is theoretical, that triage actually should bypass treating those who are too sick to benefit. Or the reverse pole, too well to absolutely need the resource. So in fact, what you get here is that triage is really there to treat the moderately ill. And that should be the focus of efforts. In other words, those who are well enough don't need the resource right away. Those who are too sick won't benefit from it. So the focus here is on people who could use the resource in the most effective way. And clearly that shades towards the utilitarian position. So to some, when there are two patients waiting for ventilator, but only one available, in this view, if one patient has the potential to live a full lifespan after being saved and the other is terminal, one should prioritize the patient who's more likely to live a full lifespan, even though obviously you're trying to make, you're trying to take great care to save all human beings equally with no priority based on anything, no socioeconomic status or race or gender. You're trying to do that equally. But an individual who desperately needs this might gain priority. None of these ethical positions are foolproof. None of them are comprehensive in the sense that they cover all of the kind of complaints or emotional resistances that we might put up to them. But what I hope I've been able to get across to you, even in this brief way, is the often heartbreaking set of decisions that heroic doctors and nurses face, and they face them in real time. They don't have the luxury, of sitting down to an ethics seminar when patients are being wheeled in and they're very sick. So just the act of doing triage can be traumatic in and of itself for everybody involved. So I think all medical care workers, especially those on the front line, deserve our really eternal gratitude. And may we see an end soon to this global suffering, and may all our families be reunited. in health and in joy. Thanks very much.
Dr. Malamet, thank you so much for your presentation. We're actually going to bring back Dr. Buchman and Dr. Singer for a fireside chat where I'm noticing that some questions have started to come in from the audience. That's great. Please feel free to send your questions in the Q&A box at the very bottom of the screen. I'd like to begin. I mean, obviously, all three presentations give us a very good launching point for our discussion tonight. You know, especially when it comes to the question of resources, and perhaps we begin there. I will pose this question to all three doctors, beginning with Dr. Buchman. When there is a decision to be made for treatment and the resources are scarce, and you touched on this, Dr. Buchman, already, who makes these decisions about the distribution of resources, and what does the process itself look like?
So thank you very much for the question, Galit. So you know, I'm just going to begin where Dr. Malamet left off in the issue of moral distress. You know, moral distress occurs in physicians and other healthcare providers when we know we can, there is care that we can give, but we're unable to give it. And to put the decision, say, on one doctor, say the chief of medicine or critical care, is really too much to bear. For any one individual. So it's very important that this be a shared decision and worked out in advance. So in Ontario, they've come up with this critical care triage plan, and it's the case in Canada because health is provincial, and on basis of those ethical principles that I referred to earlier. So it is a committee. Okay, it's a larger scale provincial group. And one of the important things is that there's very clear tools that you use to evaluate what a person's short-term mortality risk is. It incorporates all the principles that I referred to earlier, such as non-discrimination, protection of individual rights, fairness, equity, proportionality, beneficence, respect for autonomy, etc. And it also is the same, so you're not going to get one kind of care in one hospital and another kind of care in another hospital or in different regions within the province or across the country. Standardization is really, really important. And in the event, for example, it's all planned out like a flow chart, and if you found that you couldn't decide, say, between two individuals, they were equal on all sex, then you would actually go down to randomization. So literally a lottery that would determine as the fairest way. You know, these are really hard things. We were on the brink here in Ontario. We seem to just be pulling back. No one wants to go down this road.
And Dr. Singer, Dr. Malamet, would either of you like to add to Dr. Buchman's comments?
I'd just like to say that
Sure.
in my experience, very often you can save a lot of triage if you do it in advance. In other words, if you can manage to make some kind of a meaningful conversation with the patient before, he may not even want to come to the hospital. Many people come to the hospital not having the faintest idea what it's about. And they end up being ventilated and being treated in all kinds of ways which they never wanted and never would dream that they would want. So I think if we can do something before the patient comes to the hospital, we'll probably be able to save a lot of the agony, both to the family of the patient and, of course, to our colleagues.
You know, one hot topic right now in Canada and in many places really around the world has to do with the COVID vaccine. So again, resources to an extent here. With limited resources, how are decisions made about who gets the vaccine? You know, healthcare workers, vulnerable populations, including the elderly or the homeless or marginalized communities. Dr. Singer, perhaps we can get you to weigh in first on this topic since Israel has already vaccinated a large percentage of the population.
Yeah, that's why the situation in Israel, I think, is totally different to what it is and the situation of vaccine is not the same. I mean, even if somebody is not vaccinated, and if he takes good care, isolates himself, wears a mask, the chances of him getting the infection is low. So that it's not a question of life and death. It's not that if he gets vaccinated, he'll live, and if he doesn't get vaccinated, he's going to die. So I think the situation is rather different. Basically what's been done, and I'm not sure what I think it's usually a combination of medical epidemiology and, unfortunately, I'm sad to say this, and politics. To my mind, that's what's happening. And I think in Israel, at least, the decision to vaccinate, to prioritize vaccinations to the frail elderly and to the healthcare workers was a correct decision. I think that's what had to be done. With regards to Canada, I don't know. I'm just not.
And that's where we turn the question over to Dr. Buchman in regards to Canada.
Yes, so Canada's rollout of the vaccine has been problematic, but there are clear ethical principles as to how this should be done. And the plan really lays out, again, those who are high risk of severe illness and death from COVID-19. So those with advanced age and those with high risk health conditions. Then it kind of goes to those most likely to transmit the disease to those at high risk. So it is frontline healthcare workers or that can get it. It's essential to maintaining the COVID-19 response. So you have to vaccinate those frontline healthcare workers. You also have to deal with people who live in congregate settings like long-term care facilities, like shelters, or household contacts of those at high risk. Then we have to contribute to the maintenance of essential services. If we lose all those healthcare workers, we have no healthcare system. We won't be able to vaccinate. So we have to also vaccinate the police and firefighters. And finally, we have to vaccinate those who are at high risk due to their working or living conditions. So people would know who know the Toronto area, the Peel region in just west of Toronto, high center for distribution and manufacturing. There are people who, mostly racialized citizens who are new to Canada, who are working in these distribution centers, so that those of us who are more fortunate can work at home. And they are living often with many people under one roof, and they're exposed at work. They need to be vaccinated. So there's a sequence there. And you don't take into account the principles of equity and how feasible it is and how acceptable, what the knowledge is about vaccines, address information, communicate vaccine decisions. All those principles have to be underlying those sequences that I referred to.
Okay, very good. And Dr. Malamet,
I just want to jump in on this.
Right.
I think that the populaces that Dr. Singer and Dr. Buchman are talking about are the easy part, right? The elderly, healthcare workers, people who are vulnerable. I'd include teachers. But I think there's a bigger picture here, which is the mentality of different populaces, right? Can people be disciplined and wait and understand that maybe the vaccine should go to those who need it more? In many ways, COVID is like a Rorschach of how different societies operate and what they value. Because you know that countries have personalities just like individuals do. And for instance, throughout the coronavirus, certain Americans have been utterly preoccupied with their personal autonomy and not having their freedom impinged by, say, having to wear a mask. What happens when selfish interests collide with the public good is one of the main moral questions of our time. There are already multiple stories of wealthier or more well-connected people trying to jump the queue in certain cities to get the vaccine. And that's the bellwether of the mindset of a culture. In places like New Zealand, Australia, certain European countries like Italy, the individuality kind of ethos is tempered by a knowledge of the larger good. And I'll just close this by saying that there was a case in Florida earlier this year that was ruled on at the end of July in Palm Beach County, where the state had tried to mandate mask wearing in certain instances, and 4 people went to court to sue for the freedom not to have to wear the mask. And the court ruled that the state has every right to impose a mask wearing. And in the ruling, they wrote that constitutional rights don't allow citizens to basically shirk There's social obligation, and I remember one sentence particularly from the ruling, which is that we don't have a constitutional right to infect others. And I think that's worth considering, right? That it's not just a question of technical hospital policy, it's also the mindset of human beings, and that mindset is often culturally determined.
Mm. Dr. Singer, I see you nodding your head. Is there something you wanted to add to that point?
I think it's very, very well stated. I totally agree.
Okay. I'm going to take a look at some of the questions that are coming to us from the audience members, because there are quite a few of them. I'll begin with a question that comes to us from Karen and Harvey Minden Shipper. I hope that I'm pronouncing your last name correctly. And they ask, is it feasible in Canada to provide care at home, palliative or symptom relief, and thereby relieve the pressure on hospitals? And as a follow-up to that, are there resources to do so? Dr. Buchman, perhaps we begin with you on that one.
So I spent most of my life providing home-based palliative care, so I'm a strong proponent of that. The problem that we have in Canada is maybe only up to about 30% of Canadians actually have access to good palliative care. So in certain places there are resources, but it's inequitable. I'm going to refer to what Dr. Singer was referring to earlier, the importance of goals of care conversations for advanced care plans to really allow people to express what they want. And yes, it's absolutely true, and we found this in studies that we have done, that when people are allowed to express their personal wishes, and when they truly understand what the evidence is for the intervention, and they combine that with their personal values, their faith, that's how we make the medical decisions. And when they learn about what they might experience in an intensive care unit or in hospital, they don't want to come in. They don't even want to come in now with the restrictive visitor policies where they might die alone. I hinted at that in my presentation. Mm-hmm. So the importance of, that's why we've developed this program at North York General, that actually if people come in to the emergency room and the emergency physician identifies them as maybe a palliative approach would be useful, we kind of come right in there. We're kind of this on-call team that will go in and have those goals of care conversations that haven't been done yet. And the vast majority of people are choosing to get their care at home. We have a really rapid turnaround time, and we can provide all those services, and they can be with their loved ones at home, getting the best of medical care. And that's why I make the point, we can't abandon palliative care. We need to advocate for greater resources. Using technology, I spend most of my day now doing virtual home visits, and we're able to do that. So yeah, it's a great question, and we need more resources to be able to do that.
Okay. We have another question from an audience member. The name is Gorit Lotan. And the question is, could someone address the issue of many surgeries being put off in order to prioritize ICU beds for COVID patients? For instance, cancer, there is already a projection that the number of advanced cancer will be diagnosed in greater numbers because of delays in diagnostic and in surgeries. And she thanks you. Does anyone feel comfortable addressing the issue of surgeries, or is able to, I should ask?
I can, unless one of the other speakers wants to look at that.
Yeah, why don't we start with
okay. Yeah. It's a really critical problem. And we are going to see many more deaths, and there's lots of literature as a result of the fact that we haven't, that we put so much effort into COVID, and we've delayed other surgeries, delayed medical care, delayed primary care. And so there's a huge number, there's a big literature now that shows that we're gonna have increased consequences. And not only the regular kind of illnesses, but the issues of mental health, addictions, the impacts of social isolation are really, really key. So how do we balance the ability to have to look after COVID patients, the overall population health, and the need for so many people that are suffering unbearably because of the delays in their medical care? So that's something that's always occurred to us, and that's why I continually hear about the problems of the public health measures that we need to contain this virus. And we can't forget all the other conditions that people suffer from.
Just like to add to that. Oh, go ahead, Yoam.
The delay in care is from the two perspectives. On the one hand, it's right. internal medicine wards are transformed into COVID wards, and there's no place. On the other hand, there are very many patients out there who will never come to a hospital because they're afraid they'll get COVID. And so they defer their care voluntarily because they're afraid what will happen if they come to the hospital. So it comes from both directions. And the results are horrendous, horrendous. I'm sure many, many more people will die from comorbid conditions than from COVID itself because of both of these things.
I think that the question goes beyond even alternative medical issues that are being ignored and opens on to a vast panoply of conditions around the world that get sidelined. Obviously, economics, people losing their living, and in some cases losing their life because they don't have food to eat. And this raises the issue of the difference between COVID in the West and COVID in developing nations. If you live in the slums or the streets of Mumbai or Rio de Janeiro or other places, you really can't afford to be doing what we're doing right here. You can't be sitting in your home with your computer doing Zoom stuff and making a living that way. You've got to be out on the street peddling your wares. And if you don't, you face an agonizing binary, which is, if I go out on the street, I could catch COVID. And if I don't go out on the street, I will starve. And that is a very real situation for many people. So the question is an excellent one, you know, the issue of putting off other surgeries, but a lot of things have been put off, right? Recently, the Lancet Medical Journal said that hospital budgets, health budgets of governments only cover about 2% to mental health. Not talking about an overall government budget, just the government health budget has a minuscule proportion. And yet there's a mental health crisis around the world that's due because of, that ensued because of COVID. So all of these things are kind of ancillary consequences of what's occurred because of the focus on the pandemic.
I have a question, actually, Dr. Malamet, from Melissa Potashner, and this is specifically directed to you, but I think the other doctors can also weigh in. Do doctors make these ethical decisions based on their personal morals and ethics, or do they learn this in medical school? Are they mandated by their governments if there is universal health care? So we'll start with you, Dr. Malamet.
I mean, in some ways, I'm the one you should look to last because I never went to medical school. But I think that there are, you know, I've asked doctors about this, right? As an ethicist, I've asked doctors, is there ethical training in medical school? And it appears that there is, or that it's a growing field. But I'm not sure that they're prepared for this level of intense ethical conflict. I don't think anything can prepare you for it, really. But I'm not sure that the training exists to really, you can role play, you can go through things, but I think that in general, the field of ethics is central to the way we live, and I'm not sure that it's really stressed as a society, but I'll let my colleagues answer the professional part about what goes on in medical school.
Sure. Dr. Buchman, did you want to weigh in?
Sure. Well, they're sure learning on the job right now. So, you know, seeing the difficulties and the challenges that are there, these discussions have become paramount. Yes, bioethics and these challenges are included in undergraduate and postgraduate medical education in Canada. But, you know, it's sort of cramming in everything. We could always use more. And I think we always have to have the opportunity to bring up the ethical dilemmas and conundrums that we see every single day. Our field, mine and Dr. Singer's field of palliative care is huge with them all the time. So issues of autonomy, for example, are really everything. I had to discuss this with a student the other day that a patient who came in and may face triage may have his or her autonomy compromised. You know, so we have to, I think, as practitioners, take advantage of every opportunity that we have because it's there day to day, not just within the pandemic, but to bring the issue of ethics into our clinical discussions.
I think it's a mixture of all together. We learn it, we experience it, I think the important thing is to be aware what's going on and to reflect on what happened and learn from our mistakes. I can tell you many of the white hairs on my beard are due to these mistakes. And the important thing is to learn from it and to make sure that it doesn't happen again. So it's a question of learning, it's a question of experience, and I think it's also a question of honesty.
Very good. Thank you all. Another question comes to us from Marsha Sokolovsky, and she asks, what can be done to address the issue of vaccine hesitancy amongst racialized groups who have understandably developed mistrust due to past issues with medical experimentations? I'll address this question to begin with, at least, to Dr. Sandy Buchman, please.
Okay. It's a great question and a very important question. Many of our racialized communities, in particular our Indigenous community in Canada, has very evidence-based, well-based distrust in our healthcare system that they have not been responded. So why wouldn't they be hesitant about taking a vaccine? I think that the important way to address this is to really listen. Okay, really listen to what they're feeling, you have to explore, be in a non-judgmental way, you have to explore the reasons why they're reluctant. In addition to sort of the education, it's important to get allies, to people, say, from that person's community, from their background, who advocate, who can share that they have trust in this particular treatment, which is a vaccine. So we must listen, we must respond, we mustn't force. We just try to have to take a slow, pervasive approach to gain a person's trust. That often has to do with the patient's family doctor, the trust that they have in that relationship, and others within their community who can model the way.
I totally agree. I think the question of trust of the individual is critical here. I can tell you that in the last month, I've got 17 phone calls from Bedouins living around Beersheba asking me what I think about vaccination. That's a question of trust. I think that's the bottom line. There's no other fast way around it. It's listening, it's enabling trust, and then advising.
I'm curious about what happens when I agree that you need patience and you need to have a conversation, and there are many demographics though that are rejecting vaccines, and that is troubling, not just for them but for the individuals and the societies around them. And what do you do when you have a significant section of the populace that will refuse to get vaccinated? What will the future like that look like? And it's obvious that we have to talk about the question of whether the state should be mandating certain policies and actually overriding personal preferences, which is something that people don't like because we've been raised on autonomy in our mother's milk. But there are people who've argued this for a while. In 2017, there was a bioethicist named Alberto Cipollini who wrote a book called The Ethics of Vaccination. This is before COVID. And he argued the government should be able to enforce vaccination as a basic moral good of society. And I don't think we're necessarily at that point in terms of overriding personal consent. But what would happen if we got to an acute crisis? Currently in the West, nobody has to be vaccinated. But there might be consequences if you don't, right? Because in the United States, for instance, if parents refuse to give their kid an MMR vaccination, so schools can refuse them entry. So it's not enforced, but there are consequences. And we'll see if some sort of similar policy comes into effect with COVID if there's a large group that doesn't want to be vaccinated.
We have a very interesting question here. It's an anonymous attendee asking, can you help us understand the impact of having to make these decisions on the decision makers and what support can be given to these people who are forced to determine resources use? And perhaps we begin with Dr. Buchman on this one as well.
Sure, thank you. Very important question. This is the example of moral distress that I was referring to earlier. When you know you can really help someone and you may not be able to. That ventilator may not be available, that particular treatment may not be there. And those that are in a decision-making capacity there can't cope with that. You know, it just adds to the stress and the burnout that healthcare providers are experiencing through the pandemic. People are burning out. And it's, you know, burnout was a huge problem. At the Canadian Medical Association, we've surveyed at least a third of physicians report serious burnout. A slightly smaller number report serious depression. We're seeing that they are not getting a break through COVID and are really struggling. So when you add the moral distress on top of the burnout, one of the reasons we got to get this thing under control, because we are going to lose these healthcare providers. We're going to see increased risks of serious depression, suicidality. That's already happened with a couple of physicians in Quebec just recently, substance abuse, PTSD, etc. So it's moral distress on top of burnout. It is not a good situation.
Dr. Malamet, would you like to?
I think plain and simple, physicians are being traumatized, just like other forms of trauma. And I really agree with Dr. Buchman. And I think, you know, when you asked earlier about who makes the decisions about the distribution of resources, those decisions should be made before patients ever enter the room, because there should be a clear hospital policy, because triage can be awful and traumatizing. And it's traumatizing because doctors dedicate themselves to helping people. That's their raison d'etre. And now they may have to turn people away. It goes against their instinct. There's a lot of guilt that comes with that. And there should be a clear set of guidelines which are instituted by the hospital administration so that doctors and nurses already have a sense of what the triage framework would be at their hospital. So you don't have to be left with all these decisions in the moment in the emergency room. So, I mean, I think that there's a huge mental health component that's going on around the world, and physicians are part of that mental health component. If I can just say one last thing, it just, all of this speaks to what do we really prioritize as societies. And when you talk about what we prioritize in a personal life and in a government life, it's a few things. What do you spend your money on? What do you spend your time on? What do you invest your energy on? What's the nature of your conversations? In Hebrew, the word mashber means crisis. It also means a birthing stool. It means that every crisis gives birth to some new way of thinking. And I think that this is a crisis that has to give way to a new way of thinking, because we have to consider what do we actually value as societies, and how are we going to adjust in light of what we learned from COVID.
Dr. Malamet, we actually do have a question about, from a Jewish ethics perspective. Is there an obligation to accept being vaccinated since it's not immediately life-saving?
It's like a murky area. When you talk about from a Jewish point of view, the question is whether you're saying, if you went to the rabbi, what would that rabbi say? And of course, you don't really have case law that mandates that you have to have the vaccination. A good precedent for this is smallpox. In the late 18th century, I think it was Edward Jenner, where smallpox vaccine is developed around 1796, but the technology had already been known prior to this. So rabbis were already dealing with this question, and there's literature where it's clear that Jewish communities are not necessarily convinced of vaccinating, and rabbis are not forcing anybody to vaccinate. So it would seem to me that this is one of these areas in Jewish law where you have to allude to larger principles and hope that they stick. What larger principle? Obviously, the idea of saving a life, right? In Hebrew, sakanat nefashot. So you can throw that at people and say, it's a Jewish, imperative to get a vaccine because of saving a life. But you're now going to run into that minefield that we've seen in the last year, which is people reject that logic and say, well, it says it's not really going to save my life, and I don't really need it. And what are you going to do at that point? Halacha can advise, but it can't coerce.
The next question is actually for both Dr. Singer and Dr. Buchman. And Dr. Singer, you're in Canada at the moment. The question is, how would you compare attitudes towards palliative care in Canada and in Israel?
How would I what? I didn't understand.
How would you compare attitudes towards palliative care in Canada and in Israel?
Right now, the thing sort of that strikes out my mind is that palliative care in Israel is part of what's called a basket of services. So, which means that every person is entitled to get palliative care, whether at home, whether in a hospital, whether on an outpatient basis, and it is basic right. And the question is actually, is palliative care administered according to the law? Well, obviously not as good as one might want, but seems to me, at least from what I've seen here, and it's very limited. What I've seen is very limited. It's only in small parts of Ottawa that palliative care in Israel today is at home and in the community is more available than is what I've seen here at the moment. But again, in Israel as well, it's not as it should be. A, because the services don't exist everywhere, and B, because the healthcare providers don't have resources, usually the human resources, to provide palliative care as it should be. And the other question is obviously not only whether palliative care exists or is available or not, but if it is available, whether what's available is worth the word at all. Because to administer palliative care for a physician to be in charge of 190 or 250 patients at one point in time is not really the standard one would ever want anybody to be at. So that's a question which is probably even more difficult to assess than whether it exists or not. But perhaps Dr. Buchman could tell us more what's really going on in Canada.
Front, yeah.
I can speak to the Canadian experience, but it's hard to compare that. I mean, I have many colleagues in Israel who are advocating for more palliative care within Israel. Part of what I hear there, and it's a similar problem here in Canada, is just about an attitude about the acceptance of palliative care. So it's a whole concept of how do we accept death and dying? Do we accept it as a normal part of life, just as we accept birthing? And so a lot of people are in, and we are in a culture in Canada that's often death denying. So we don't get sufficient education in palliative care in medical school, but it's much better than when I started out, which was literally nothing. We are improving, but yet physicians don't necessarily have, and many other health professions, nursing, social work, they don't necessarily have the exposure that they need. And we are still in a culture where the majority of people actually equate palliative care with just end-of-life care, so the very last days or weeks of life. When palliative care is an approach to medical care that should be started much, much earlier, often earlier, the beginnings of a diagnosis, where you can look after pain and symptom management, you can deal with the psychological and emotional consequences of illness and the spiritual and existential suffering. So these are all the domains of suffering. We don't have sufficient knowledge amongst our population, and therefore amongst our politicians, to put enough funding into providing access to palliative care. This is an ongoing battle here.
And just to note, we're going a little bit over time here, and Dr. Malamet, I know it's very early in the morning. Are you okay to take a couple of more questions from our audience?
Oh, I'm like wide awake now.
Okay. All right. So this next question is addressed to Dr. Buchman. it comes to us from an anonymous participant, and the participant asks, I wanted to know whether you obtained a recent copy of the Ontario Protocols, January, February 2021, and if the Ontario Protocol, in your opinion, conforms with the principles which you prioritize, the collection of and assessment of objective data, and the respect for non-discrimination and human rights.
Yeah, so I have seen the protocol, and yes, it follows all those principles, ethical principles that I outlined earlier. I think it's actually an outstanding document. A lot of work and effort has gone into it, and it's I'm sort of proud that in Ontario we have such a principled and ethical-based document, and I think this can really help providers and the people that are forced to make these kind of decisions. That will deal with the moral distress issue that we referred to earlier.
Okay, very good. A question now too about the decision-making process. And the question is, why does the decision-making process not include family and or a patient if they are capable of doing so, of making a decision and being aware through the process of it? So decision-making should be shared is the comment. And the question again is, why does the decision-making process not include everybody? Dr. Singer, perhaps you can get us started on this one.
To my mind, it does include everybody. I mean, according, at least in Israel, I don't know what it's like in Canada, but Israel, it's forbidden to force somebody to undergo something that he doesn't want. So certainly, what I'm saying is, and what I've said is that in order to enable somebody to make a decision, one has to explain to him what the consequences of that decision are. And that takes time, and not many patients don't receive that, are not privileged to be able to have that. But there's no doubt in my mind that all medical institutions, the ideas of the patient, for sure, but also caregivers are certainly taken into account.
Dr.
I think it depends what the question is asking. Is it asking they should be involved in decision-making about the allocation of resources? So the allocation of resources is made by the hospital, and I think for good reason, because you can't have a kind of marketplace where everybody is kind of advocating for their resource, because the individual is not taking into account the good of the larger whole. They understandably want a decision about the resource for themselves. So if it's about access to the resource, then I don't think I think that decision should be made by the hospital. If we're talking about other kinds of medical decisions that might involve consent or giving people the dignity of agency, then I do think they should be involved. So it depends on what the case is.
And Dr. Buchman, would you like to weigh in?
In our field of palliative care, we actually see the family and loved ones as a unit. We're treating the patient, of course, but we're treating the unit too, and the impact of the illness. Ultimately, it comes down to the individual's autonomy, but you try to facilitate a shared decision-making process. So I'm going to take it from Dr. Malamet's sort of comment about, here's this question about, is it about policy or thing? But if we bring it to the clinical situation, if that's what the questioner is referring to, we always try to make the effort to include and get the support of the loved ones of that circle of care around that individual patient. And you can't always get it. There can be significant disagreements within a family, but the more support that you can get, where you can get people on the same page, we can get their understanding, the better the outcomes are. So ultimately, yes, it's the individual's decision in Western society and according to Western medical ethics. Different, and of course in Canada we have a multicultural, multi-religious, multi-faith communities, and there are different ethics for it, but we have to follow many times individual ethics where autonomy is paramount. So we respect that and try to get others around to support the decision of the individual.
We had a conversation with Dr. Daphne Grossman yesterday, myself and a colleague of mine, and she shared a very interesting question that I'd like to pose to everyone. On the topic of ICU beds in Canada, we can't withdraw a person from life-sustaining therapy, such as ventilators, without consent. But what if this person is unlikely to survive, and a person who is more likely to survive needs the vent? And I think this question also in some ways relates, Dr. Malamet, to the scenario that you presented in your presentation. So perhaps we begin with you.
Well, it's kind of what I was talking about before. It gets to the question of, in a sense, whether the governing authority, whether it's the hospital or the state, can mandate certain policies and override personal preferences. Right. So if you have, you know, in a way, if you try and envision a kind of apocalyptic nightmare scenario where you have a huge throng of very, very sick patients taking up inordinate amount of resources, machines with very little chance of getting better, and you have this huge queue now of people who could use the resources but can't get to it. So the question is going to be whether we override personal preference in the name of the larger good. There's a sort of cultural shift that would have to take place. And again, a lot of these issues are interrelated. We have granted, I mean, Canada's already a little bit more socially oriented, but in many Western countries, the idea is that the I is king. Like, what I want is the way we think policy should run. So you have a tricky balance here, because as Doctors Buchman and Singer have pointed out eloquently, personal choice and the dignity of allowing people to be involved in their decisions is really just good ethics. It's also just good medicine. It's paramount to get that kind of cooperation. I'm just wondering what happens when you don't get that cooperation. What happens if a society hypothetically begins to act selfishly? I do not want to do this. We saw this with masks. We could see it theoretically with ventilators, and we could see it with vaccines as well, as people try and jump the queue. And so I think that we have to also be responsive to the idea of what would we do if people don't behave themselves, right? Because ethics isn't just about when people behave well, it's actually about when they don't. And what kinds of responses and reactions do we have to have when people are not holding up their end. So although it's kind of appalling to think of overriding somebody's preference and just yanking them off the machine, I think that we have to think of the larger ramifications of not doing so as well.
Dr. Buchman.
Jump in. Certainly in Ontario, this is an issue of legal consent. So if a patient or their substitute decision maker does not provide consent, then that ventilation cannot be withdrawn. Okay, it's pretty clear in the law. Not saying right or wrong, but the law is pretty clear on that. And we've had challenges like that that's gone to the Supreme Court in Canada. Something called the Rizzulli decision, a patient at Sunnybrook Hospital a few years ago, where the physicians wanted to withdraw life support, and the courts actually ruled against them. And it was the family's substitute decision makers' decision to maintain that patient on life support. So you can't do it. Bottom line.
Dr. Singer, would you like to weigh in as well?
I think that usually, luckily, it's not so clear cut. It's not that there's one person there with no chance and taking all the resources, and another young guy who just needs a day or two of ventilation. That's usually not the case, luckily. And usually, if you bring it down to the fine detail and the individual case, the decision is usually much easier. And sometimes it's very, very difficult. And there's no right and wrong. And yes, sometimes it's a question of, you can say fate or whatever you want to call it. But usually, fortunately, from what I've seen, is it's a bit easier than that, because when you go into the fine details of really what's going on, things look a little bit more clear.
Dr. Buchman, Dr. Singer, and Dr. Malamet, thank you all for your time tonight. Our time, unfortunately, is up. Each of your presentations, as well as your thoughtful responses, will go a long way in our own understanding of the pressures that the medical community is under when it comes to making split-second life or death decisions, especially right now as we all grapple with COVID-19. I would like to take a moment to thank our collaborators as well at the Canadian branch of the International Federation of the IMA, Dr. Rose Geist and Dr. Daphne Grossman. We also thank the Dr. Edward Feldman Memorial Fund once again for your sponsorship of this important event. A huge thank you to our team from CABGU, including Toronto Executive Director Shimi Wenner, who has worked closely with Dr. Geist and Dr. Grossman on this event, Zach Ostroff for his technical brilliance, Elise Mathalon for live tweeting, and of course our CEO, Mark Mendelson, for your continued leadership. And a special thank you also goes out to BGU Vice President Jeff Kay for your continued guidance and support. Thank you all for joining us this evening, and we wish you health, all the best, and be safe.